slides, and this is my spot. It's okay? Good afternoon. This is the best time to give a talk. You know why? There's some research I told you, I'll explain you after the breakfast, the first one, and after the lunch. Because half of you are sleepy, the half of you are very focused because they have a high level of glucose. By the way, it was, I'm coming from Israel, Tel Aviv. It's big. It's not the biggest, but one of the big centers in Tel Aviv. I'm working in this hospital here. This is our hospital in this area. The sea is just a few kilometers from there. Yes, it's for helicopters here. Helicopter can come to bring patients from war or from car accidents, just on the spot. And below is the surgery department on the -2 floor. I'm leading the pain clinic. It's called now Pain Institute in my hospital. It's very new. We just reopened it this month. We have a load of 100, 120 patients per day, working 8 to 8. We are around 10 doctors, psychologists, chiropractor, and many other therapies that are working together. I believe that multidisciplinary therapy is the best way to treat the chronic pain patients. Also, we have a huge acute pain service. 25 patients per day are seen by our service. And we start also children pain service last year. So let's talk on what's called mechanism of malignant bone pain and visceral cancer pain. It's a very heavy talk, so feel free to stop me, ask me, don't be shy, and ask me whatever you want. Probably you know this is too. Can you see something there, the colors? No.
The yellow one.
The yellow one, okay. Probably you've seen this kind of slides this week a few times. So there are few models of cancer pain and cancer pain treatment. This is one of the models, and this is the other models. Disease direct therapy and patient direct therapy. Treating the disease and not looking that much to the patient, and treating to the patient and not looking at the disease. Palliative versus curative therapy. Family or patient-directed or disease-directed therapy. The main issue in these days is that we have many survivors. And I'll point out why this makes, for us as clinicians, a very big difference. Treating the results of our treatment to the patients. We are cutting the patients, burning the patient, irradiating the patients, giving them therapy. At the end of the day, they are cured, but sick. This is a new theory of what's called the survivor of cancer. There are many now, because we know quite good today to treat patients with cancer, to treat the disease, but not the patient. There are few classifications of cancer pain. I'll go for this one, the somatic, visceral, neuropathic, and headache and facial pain. Somatic, we'll go, this is my talk today on somatic bone metastasis. Visceral cancer pain, we'll go on this issue also. A neuropathic cancer pain that usually is a combination. There is no really pure neuropathic cancer pain. Somatic plus cancer plus neuropathic, somatic plus visceral or neuropathic cancer pain. And of course, facial have some neuropathic component. And the headache, this is very focused type of cancer pain. And now going on to the metastatic bone disease, is among the most common cause of cancer pain. However, a significant number of these lesions, do not cause pain. And many times we can find doing X-ray, chest X-ray to a patient to find metastasis to the vertebra without any complaints. These are the chart of bone metastasis from carcinomas. You see, vertebra is the first place. Long bones like the femur is a very important place, sacrum, and all together. And of course, many on the chest. Just statistical, I don't know why. 60% of the patients with bone metastasis are men and 40% are women. Do you think why? Yeah, but they're not, and breast cancer. We don't know, I don't know. I found it is statistical issue. Of course, myeloma and is one of the highest incidence of bone metastasis in cancer, but also prostate and breast. By the way, they're the same, more or less the same. So there is not a reason for this difference in men and women. Do you know what means osteoclast versus osteoblast? The difference? Osteoclast versus osteoblast. Okay, because I'm going to use a few times this issue. 5 specific carcinoma account for more than 80% of skeletal metastasis. This is important to know. Oh, my place is here. Breast, prostate, lung, kidney, and thyroid. And again, breast and prostate cancer are sending the highest number of metastases for both sex. This is the clinical aspect of metastasis. The hallmark of metastatic bone disease is localized pain. Night pain, pain at rest, and pain with weight bearing. If you have a metastasis in the femur, when you walk, you'll feel the pain. Probably when you stay, not that much. But again, depends where, and usually a person doesn't have one metastasis at a time. They have 2. One we know about it, one no. And other presenting symptoms are variable and depend on the bones involved, like limping, lower leg, frozen shoulder, difficult breathing when is the chest. This is a picture from an operation. But there is not only pain, fracture, hypercalcemia, spinal column compression, bone marrow suppression, and third of the patient will develop at least one complication of all the patients, like fracture, hypercalcemia, spinal cord, and bone suppression. And now, as I said at the beginning, there's a changing epidemiology of cancer pain. In the past, I think 100% of the patients have been suffered from tumor-related pain. Now, we are producing pain by surgery, radiotherapy, chemotherapy, hormonal therapy, and many other treatments that we are giving to our patients trying to cure them. And again, a patient who survived the cancer can have a very bad quality of life, reduced adherence to other therapies because pain, just pain. He's cured, but suffering from different, mainly neuropathic pain, but also other syndromes. And now we are going to the theoretical part, coming from the clinic to the theory. Why metastasis can cause pain? Do you have any clue?
Destruction of the bone, destruction of the bone tissue.
Why destruction of the bone may cause pain? Okay. The periost is very well innervated. So if I have a metastasis into the bone, it's less painful than when the periost is disrupted. Okay. And you have bone pain due to 3 primary bone tumor, sarcoma is an example, bone metastasis, the second one, and cancer treatment. This is a schema on how are we classifying this disease. This is the epiphysa. And these are chondroblastoma and osteosarcoma, chondromyoid, and all these are round cell lesions, dysplasias, solitary bone. A good oncolog and a good specialist in Röntgen can define type of the cancer, pathology of the cancer based on the appearance of metastasis. So, background pain is 90% of the symptom, but spontaneous pain on movement, mainly if they are on the limbs in these patients. The mechanism is more or less like the primary malignant neoplasm. After that, they cause a new vessel formation, invasion, and embolism on off. When we have bone metastasis, there are, in this area, tumor cell, extravasation, adherence, and again, vessel formation. Bone metastases are a common cause of cancer-related pain, with metastatic cancer invading, going to the bone in up to 85% of the cases. And the answer of what I asked before. The periosteum and the bone are richly innervated by primary afferents, expressing neuropeptide, vasoactive intestinal, and neuropeptidergic, C fibers, valinoid, and sympathetic neurons. And the other issue is what the inflammatory soup. When I make a lesion in a bone, there are many things that are coming to treat the idea. There's a huge inflammation around the metastasis or the tumor. This is what's called the inflammatory noxious factor, bradykinin, prostaglandin, nerve factor, serotonin, ATP. However, doesn't matter what is the lesion. There, even after the operation, when I cut something, when I treat a bone fracture, this is the results of the injury of the bone. And after that is going up to the cord and the spinal cord and treating the pain. There is no pain in the bone. How can I say? There is no really pain in the leg or in the arm. The pain is up, the upper level. It's the perception of something. I don't know if it's hot, cold. I need to have the perception of something. The pain is a perception of objective or subjective injury. I don't know. I can decide that it's not pain for me. I can decide that it's something nice, like fakirs in India. They feel exactly, I don't know, not feel. They have the same injury as you, but he's laughing and you are crying. So this is a pure perception. His brain decided that it's good for him. He was educated to go on this direction. And you can educate someone to perceive things in different way, like football players. During the match, they don't feel nothing. If they don't have a broken leg or something like that, they're not stopped. They'll cry after the match because they are driven to finish the game. And you can do this for almost everyone. There are many techniques of mindfulness and how to feel and how to perceive. You can treat not the pain, but treat the perception. The pain is not that easy to treat, but you can change the perception of someone for almost everything. Love, hate.
You want to say the pain is primarily neurological disease?
It's not, no, it's a brain disease. I'm not sure it's neurological disease. What is the definition of chronic pain?
Unpleasant state of being produced by...
Unpleasant sensation. Yes. What is a sensation? It's a perception of something. Yes. Doesn't matter, hot water, cold water.
Even potential damage of our tissue. It doesn't have to be by the definition of fatty. It can be fear of.
Yeah, there's what's called that's called what psychological pain.
No, this is the definition.
No, oh no, it may be something that to fear about it. So it's not a real injury. But why we have 10 people's same injury, and someone said it's 0, and someone said yes, and 5 are in the middle?
Because the centers for the pain in our brain is common. The same centers are activated in other states that are important for the emotions, for the pleasure, for the memories, etc.
What I did?
Limbic system.
Keyboard. So, do you think this cancer pain is difficult to treat after this course? Yes or no? First of all, yes or no? Yes? Difficult or easy? No, no. Average. Let's say we have a patient with chronic complex regional pain syndrome and a cancer with metastatic cancer pain. What do you think is more difficult to treat? Yeah. We have our result in treating cancer pain are much better than in chronic pain, severe chronic pain. I think in 80% of patients with cancer pain, we are doing very well. Again, we have an edge of 15, 20%, but for chronic pain, we are not that good. You can't see that well. I can go there. This is cancer. This is a normal bone. And now this is osteoclast. This inflammatory soup is very important because it's a sign of inflammation, but also influence the conduction to the brain at the end of the day. If I have a long and intensive stimulation with this inflammatory soup, interleukin, cytokine, nerve growth factor, at the end of the day, I'll finish with central sensitization. If I can treat this, it's easier for me. How can I treat this local problem? Is there anything that can act on this, what? Non-steroidal. Or? More? Mm-hmm. Radiation therapy, no. It even produce more inflammation. No. How can I treat this? It's a sort of, how many of you are anesthetist? Wow. You know what the theory is good or bad? The preemptive analgesia? No, do you know what means? Preemptive analgesia. So giving the drug, the pain drug, before the stimulus starts. It's more or less on the same idea. And one of the COX-2 inhibitors are found, it was found that may help, sort of, in preemptive, if you believe or not believe in this story. Let's go on this one. Pain mechanism. Non-steroidal. COX-2 inhibitor is a sort of non-steroidal drug. This is, again, going deep on the what is the inflammatory soup as cytokine and histamine. They are very, very important, and we don't really take care of them. We are treating pain with opioids. But again, in my opinion, any bone metastasis, you need to give NSAIDs to the non-steroidal to the patients. Again, we need to take in consideration renal function and all the other diseases of the patient. But again, NSAIDs for bone pain is very important because you treat the mechanism, not only the pain. There are not a very important painkiller, but is one of the not that many things that you use to treat the mechanism to inhibit the inflammation. This is a nice slide. We are not going to go on all the stuff, how this going on and off. Another thing that can produce pain is the acidity. When we eat something, you produce acidic environment to the around, and this can produce pain. And at the end of the day, will produce central sensitization when it's very acid environment for a long period of time. Metastasis, when is a lesion to the bone, it doesn't matter. Is metastasis or fracture is a process of remodeling, destruction, and hypercalcemia. And this in a few seconds I'll talk about osteoclast and osteoblast to understand the process. Progressive growth at the primary start, visualization, invasion, detachment, and all the stuff. And at the end of the day, we are remodeling the bone. The tumor or metastasis are remodeling the bone. But you need to understand that bone, like many other parts of our body, is not a static organ. It's an ongoing process of remodeling, ongoing process of the remodeling. Of course, in the children is very active. At our age is medium. At the end of the day is quite slow. But it's a continuous remodeling process, the bone. You can see that X-ray can be okay when you see a tumor in the MRI. You can see it in the probably doesn't produce any pain because the cortex is completely intact here. Okay. Go to this. The remodeling process is a balance between eating and producing. Osteoclast and osteoblast. This is called coupled and balanced. So we are eating osteoblasting or osteoclast and producing bone. So at the end of the day is the same quantity of bone. This is coupled but imbalanced. Is growing here but not here. Uncoupled but balanced is the same quantity but in another place. And this is completely not related. This is going here is not related to nothing. What will be the result here and here? Fracture. This is a fracture. Just minimal injury or no injury. Even walking, the wearing of our body can produce a fracture. This probably not, and this not really. But this and this will be the fracture. White and black, osteoclastic versus osteoblastic tumor. There's a long list. I'm not sure you need to remember. You need to know there are white lesions and black lesions. This means been regrowing or eaten by the tumor cell. Non-small cell cancer can also produce lots of metastases. And renal cell cancer. And many times usually it's too late to treat a patient when you have, as a first are presenting syndrome, a bone metastasis, because it's spread around. But in many causes of prostate cancer, the presenting syndrome is pain produced by bone metastasis. These are osteoclast and osteoblast. They're a nice picture. It looks like this. Eating or osteoblast is another way. Bone scan is a very important tool to find out where are the metastases, and also to find out the prognosis of the patient and to follow up the patients. It's much. You need to do probably CT scan after it, but you can see the black spots and to see the bone that are affected by metastasis. PET scans, see the metastasis. There is an issue less known than other. It's called iatrogenic bone pain. Do you know how many of you are work in the oncology departments? Okay. What's the disease that we are treating with lenograstim and filgrastim? When are you using in oncology filgrastim and lenograstim? After bone? No, after no fracture. Bone marrow transplant and in leukemia thing. Okay. Yeah. Okay. So there's not given for bone disease, but they are producing pain. these two CGSF drugs. The most complicated adverse event is bone pain in up to a third of the patient, and up to 70% of them have increased and severe pain. We don't know really why, but there are a few theories: peripheral or central nociceptor sensitization and direct effect on bone metabolism probably. But you need to know the patients with pain after leukemia, let's say, is the result of the drug, is an adverse effect of the drug, not really of the disease. No, not acute. After he's treated, he was treated, have a bone marrow transplant. He's okay, cured, and it coming with. He's a survivor. He's coming with severe bone pain, long bone pains. It's a result of the theory. There is a new. Have you heard about focused ultrasound treatment to treat the bone? It's a new way to treat. This very short movie. It's a new way to treat. It starts treating uterus myomas. You put the patient into the MRI, see exactly where the problem is. It starts with the uterine myomas. Now you are treating, and you have a focused ultrasound, high energy, treating small lesions, not very big lesions, instead of using radiotherapy. Less side effects for the patient. I'm not sure it's completely in the practice, but in research we are using this technology, focused ultrasound treatment. Look, heating. There is nothing else that can heating. The patient should be anesthetized during or sedated, no more than this. But it's less side effects than irradiation of the patients. For medium-sized bone lesions, it works well. I have the movie somewhere. Visceral cancer pain. How the viscera, why the colon is suffering from pain? Why colon? When I'm cutting the colon, the patient will be in pain or no?
No.
Yes or no? I asked colon. Why no? Okay, so and the small bowel? Also. Do you agree?
Unless just if there is any ischemic problems or...
Ischemic, okay. So, you're right. Usually the viscera, the hollow viscera are insensitive to pain. Like also the lung, liver, and kidney, and the brain. The brain is not sensitive. You can cut the brain, do anything. In my hospital, I'm doing lots of brain operation under local anesthesia. You need just to anesthetize the skin and make the hollow, and after that, there is no pain.
What kind of diagnosis are you treating? What diagnosis are you treating in neurosurgery?
With this kind, not the big tumor. There are two main issues. One is called, the tumor is very, very closed. No, not to the periods, to very vital function. And I want to monitor the patient. If I can go there without opening all the yeah, this one issue, and the second one is what's called the functional brain surgery. When I'm putting electrodes for Parkinson, when I'm electrodes for pain, when I need to monitor the patient. When I'm doing singulotomy, when I'm treating the pain by singulotomy lesions, maybe I go at the end of the, we developed in the last 2 years what's called functional brain nose surgery. Not taking off tumor, by treating with electrodes for epilepsy, quite a lot, and for pain. It's called the cingulotomy, dorsal root chordotomy, DRES, and all the stuff is called functional, and for different movement disorders. Now I'll have a big issue in my hospital. We are working a team with a neurosurgeon because all these kind of lesions have been done only for cancer / palliative / dying patients, like cingulotomy. Cingulotomy is, at the end of the day, to make 2 bore holes, very small, under local anesthesia, and to put 2 electrodes and burn 2 small center of pain perception. No one was doing this in a non-cancer patient till our days. And we have now patients that we are thinking to do for them cingulotomy. The main issue is no one knows for how long this lesion will help the patient. But it's amazing. We do this the lesion to the patients being in 1 gram of morphine per day. After 2 days, there are 0. There are no drugs. If it were, it's not 100%. No, I'm working together with a neurosurgeon. When we are doing this radiofrequency lesions, when we are doing to the cord, I'm working together with him. When he's doing in the brain, I'm not qualified to do. It's not that complicated. They are doing what's called a mapping, completely mapping, putting the 2 electrodes. Is a 5 minutes procedure at the end of the day. We prepare the patient for a few days.
And where is the place of the lesion in this cingulotomy?
Yeah.
Or what?
Yeah, it's in thalamus in a specific point. Can show you a few pictures. Harmful stimuli like burning or cutting of visceral tissue do not cause pain. I'm not 100% because the patients who are the doctors who are coming from anesthesia know that the patients feel some pain during laparotomies. They have peaks of pain during laparotomy, probably. No, the skin is, we start with the skin and are not touching the skin. We are going deep inside. You have the 200 on blood pressure and 100 the pulse. Something has happened there, probably the peritoneum or touching or the destruction of all the area. But what?
I'll tell you from experience. I had a cesarean section done by epidural, and I felt the whole operation because the epidural didn't work.
Change the hospital, change the anesthetist.
Terrible anesthesia in Australia, in a hospital. It wasn't in Australia.
And I'm sure. Where?
The peritoneum was so painful. I was awake.
The uterus is very painful when you cut the uterus. The uterus is painful. Agree with me? When you're cutting the uterus is painful.
The uterus is painful also, but the peritoneum, when they did the dissect, because they had a valve stuck in the peritoneum, there was a whole ovarian tumor. The kids saw everything was, the peritoneum was very, 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 very painful.
Okay. As I said, change the anesthetist. Why epidural? Why not spinal? Why epidural for a 5 minutes procedure, 10 minutes procedure, and don't need the epidural? Okay. For the last. The visceral pain is often diffuse and purely localized. This you don't really know. The patient are coming I have a pain in my appendix. You can't feel your appendix, so don't say it's somewhere there and it's going around and around. And sometimes refer to other non-visceral structure. Like, give me an example. Shoulder pain, back pain after pancreas cancer, and it's going in many other places. I'll show you even a picture. And there are also what's called autonomic reflexes or nausea after a sort of pain. What really causes pain is probably the distension of this hollow organ when or on the tumor reach the plexum around. There are 2 distinct classes of nociceptor, sensory receptor and viscera. One is called high threshold and one is sort of low threshold. Intensity encoding depends on how the disease is going on. And also, ischemia is usually producing pain. When you have an ischemic lesion, doesn't matter where it is, it produces pain. It's a very severe pain and very, very difficult to treat. We have in my practice many patients with ischemia, legs, and it's almost impossible to treat them. Once you are not treating the disease, the mechanism, it's very difficult to treat ischemia. Pain in the visceral structure is not necessarily linked to what's called the injury, but rather to depend to the nature of the provoking stimulus. Distension in hollow viscera, ischemia, and inflammation. I found that the distending pressure more than 50 millimeter mercury is producing pain. This is the cutoff limit. But if a tumor is growing very slowly and produce a pressure less than this, you can have a huge tumor in the intestine, and you don't know what's going on. This is one of the ideas to do colonoscopy after age of 50 or 55, or doesn't matter, and have a history of colonic cancer. Because, and you don't know really what's going on. It's not something that you can see. Solid organs are less sensitive, whereas the serosal membrane of hollow organs are most sensitive. And this is what you said, the referred visceral pain, going almost everything. Liver and gallbladder, you can feel below the omoplate pain, you don't know why it's going on. And it may be gallbladder, pancreas. Many times the patients are presenting with low back pain, treated for low back pain. A 70 years old man coming with low back pain, you are treating the pain. And at the end of the day, we found out there's a cancer. And usually it's too late to give anything to this patient, to do. Even appendix may be also in the middle, not in his normal spot. Again and again, there are many places. It's not easy to make a clinical diagnosis in visceral cancer pain. And also, after a huge operation like pancreatic cancer and Whipple or colectomy, you can have almost all kind of pain there. Related to the primary carcinoma, related to the surgery, related to almost everything, to complication after the surgery, and not easy to treat. So at the end of the day, we need to know the mechanism and to try to treat the mechanism and to have a very clear clinical idea of the patients. There probably the way to change what's called the change life in patient when it's coming to you and to have the clue to go, probably is not back pain, go to have some investigation, it may be cancer. To have some flags, red flags, yellow flags, doesn't matter the color, to see, to have a clinical clue to see, it's not my typical patients. It's not my typical patient coming with leg pain. Pain in the night in a young person, not related to any injury, starting out of the blue, or in an old patient's back pain. We need to have some clue and to have a high level of suspicion. Because if we wait another few months, it is going to be late for these patients, for sure. They are quite fast. The mechanism is fast of bone metastasis. And so for prostata. It's a very, very silent disease. We don't know really what's going on. And starting to treat them, give NSAIDs, doing some procedure. You need to investigate and to have, not everyone. I don't think that everyone have to have all the investigation, but the level of suspicion in our profession needs to be high. Because we are seeing mainly the top of the iceberg in many other things. In chronic pain is also, when you wait too much, is not easy. Once the disease and the perception is established, it's almost impossible to go back. We are in the stage of have a series of patients that we proceed amputation for complex regional pain syndrome because it was too late. I don't want to show the pictures of these patients. It was, I'm not sure that with amputation we treat the pain, but it was a cosmetic operation. It was such a bad leg or arm that we decided at the end of the day, together with the patient, to do amputation. Part of them are doing okay. Not all of them. What do you want to ask?
I missed why you performed the amputation.
Complex regional pain syndrome. If you want, I can show the pictures. It's not only for pain, also for aesthetic and cosmetic problems. They are.
I would like to see those.
You want to see? I put in. I have my computer here, so I'll show you. Where? Grotesque is more than grotesque. So thank you very much. If you have questions, I'll prepare for tomorrow.